It's my great pleasure to introduce Sandra Garrido to you from Western Sydney University. And Sandra is going to be talking to us about a very interesting set of guidelines she's been developing with various industry partners. So over to you, Sandra. Thank you.
Thank you, Jane. Okay, so yep, Jane has given a pretty good summary. It took less than 5 minutes, but we can probably wrap up now. No, that's all right. I'll give you a few more details. Um, okay, doesn't seem to want to change slides though. Yeah, so as most of us know, changes in mood and behavior are really common in people with dementia, and often it's those things like depression and agitation and anxiety that people with dementia report having the biggest impact on their quality of life. And there's a lot of evidence that pre-recorded music, simply kind of listening to some of their favorite songs, can be really effective in reducing a variety of those symptoms, in particular agitation, even where there's no trained music therapist present. But in our research, we've discovered that aged care facilities are not always using music in effective ways. And one of the big barriers to doing so is just a lack of staff understanding about the potential benefits and a lack of education and training about how to use music effectively. So we have been looking at this over a number of years, probably about 6 years now, and we undertook a co-design process to come up with some training for aged care staff. We started with a number of years ago some experimental studies where we looked at the interaction between different musical features such as tempo, etc., and the symptoms people were experiencing. We then sat down with some industry partners in aged care and developed a set of written guidelines. We then trialled those guidelines with a number of people with dementia and their carers to see whether there were positive impacts from using the music program. And then we wanted to transform that into some online training. So we then conducted some co-design workshops with carers, both in aged care and in home-based situations. And from that, we developed some online training, and we've conducted some evaluations of that as well. So I'm going to kind of briefly cover some of that. So the printed guidelines basically take people through a 6-step process that involves assessing people for vulnerability to potential negative responses, then understanding how to use music strategically to address some of the symptoms the individual is finding challenging, and then integrating that into the individual's personal care plan. So you can find the guidelines at that website along with the other resources we've developed. When we trialed the guidelines or use of the guidelines in aged care, we found that people with dementia and their caregivers were reporting significant improvements to life as a whole and to closest relationships, and that was in comparison to a control group that didn't use the music program. We also found that there were, and that was sort of over a 4 to 6 week period, but in individual listening sessions, we were also getting really positive increases in interest and initiating conversations and being involved in things that were going around them. But the other thing that still came out of it was that staff are really time poor. The program's great, it's effective, but we need streamlined processes and they need better training. So this is where we worked with the focus groups to co-design that online training. And some of the key things that came out of those focus groups were that people wanted role-specific content, so they felt it was important for people at all levels in an aged care facility to have training that was appropriate to their role. And they also wanted it to be scenario-based so that they're not thinking about theory, but they're actually thinking about real life scenarios and how that can be applied. So you can use this QR code to actually reach any of the resources we've developed. There's a free, short, interactive e-learning module. There's also a more extensive alternative credential being offered by Western Sydney University, which is about 15 hours of training. And at the end of that, an aged care or a caregiver of any kind will come out with a program that they can then put into place with individuals in their care. And there's also a website that helps to streamline some of the processes. So when we did some testing of the short online training, the free module that we've developed, we got really good response in relation to both the content, the pedagogical design, as well as sort of visually, and people were also made some positive comments about the potential impact and relevance to their role as a carer. So we're getting good feedback on that, and we're currently running a sort of a pilot test of using this training in an aged care facility and sort of providing all of the resources as a package to aged care facilities, and then looking at the effectiveness of that package and whether or not it results in changes to the way carers are managing challenging behaviours. And this is some of the members of our team that have been working on this throughout the process. So that is my brief overview.
Okay, Romy Engelbrecht, your turn.
Hi, it's Romy.
Romy, sorry.
That's okay. I'm very used to that.
I'm sure.
Excellent presentation, Sandra. Thanks.
Over to you anyway, if you would like to get your little PowerPoint going.
I am Romy. I am talking to you today about music and reminiscence therapy, specifically looking at how reminiscence therapy and music-assisted reminiscence therapy are used in clinical practice. But can everyone hear and see my slides okay?
Yep, perfect.
Awesome. Also, thanks to my supervisors, my PhD supervisors and co-authors on this submitted paper. So reminiscence is the internal externalized recalling of significant life events, experiences, or the personal narratives we tell ourselves about who we are. And reminiscence therapy is an intervention that uses these in a purposeful and directed way to improve well-being. And so this is an evidence-based intervention for things like late life depression or loneliness, quality of life, cognition, happiness, affect, and self-esteem. So some nice references there. I'm not sure if these slides are available to people afterwards, hopefully. So reminiscence is one intervention. And part of my PhD was really looking at the use of music-assisted reminiscence therapy. How can we use music and reminiscence therapy together? So we are defining a music-assisted reminiscence therapy as the inclusion of live music, recorded music, or the discussion of music within reminiscence. And the current research in this area is of pretty poor quality. But what we do know so far is that music does enhance the therapeutic effects above and beyond that of verbally delivered reminiscence therapy for things like mood, depression, anxiety, stress, social interaction and group identity, blood pressure and saliva cortical levels to a greater extent in MRT compared to VRT. So it's quite promising what this intervention or combination of interventions could provide. So to explore this, we looked at direct care workers and volunteers working with older adults, the extent to which they're using VRT and MRT, how the interventions were delivered and viewed, and the purpose and observed benefits of these interventions. So 110 respondents completed this online and hard copy survey. It was about 28 questions with closed responses with multiple choice to determine things like frequency, and then also open-ended questions, and we asked people to tell us clinical instances where they're using these interventions. So it was a very exploratory study. We just wanted to get a bit of a landscape picture about what's happening in clinical practice. So a lot of information on this one. Most respondents are using VRT in their work and regularly, which is fantastic to see that this is an intervention being used to help older adults. While MRT is used less often than the verbal one, it's used by most of the people who are making use of VRT, so that's great. The types of music used in MRT are live, recorded, and as a topic of discussion. And so this sort of formed the basis of how we started to define MRT. It's mostly used during reminiscence compared to after and before. And both interventions are sort of delivered across group and individual contexts, rather than exclusively in one or the other. So simple reminiscence, which is a thematic discussion focused on social interaction and enjoyment and positive experiences, was the most frequently reported use and approach across these two interventions. And the purposes of these interventions was for identity validation, social engagement, and boredom reduction. To complain was the least used purpose. So we asked participants to tell us about times where they had used these interventions with older people, and we found that they were often spontaneous and integrated into episodes of daily care, so during feeding or toileting or showering and the like. It sort of became clear that MRT was used when an older person communicated a musical preference. So if the person found out they really liked the Beatles, for example, this was integrated within care. Or if they had a history of playing an instrument or any sort of musical background, this is when the staff are really making use of MRT strategies. It also became clear that MRT was used as a compensatory strategy when the older people had a perception they couldn't engage verbally within a traditional sort of reminiscence, tell me about your childhood. So the outcomes were fairly consistent across VRT and MRT for social connections, mood, and then a few minor differences between the better care practices. So that staff reported these fantastic benefits like reductions in medication, behaviours of concern and agitation. There were changes to the social programs and staff handover and communication, which is fantastic. But then MRT also resulted in building some resources like playlists or legacy items that could be used for the older people at other times, which is also great. Okay, so this just helps us to describe the treatment as usual practices for MRT and VRT, which sort of helped me anyway to help make some research decisions for my subsequent studies in my PhD in terms of what are we testing? Are we testing it in group or individual? And what outcomes are we looking at? As well as maybe having a look at how we can implement these within clinical practice. So my take-home message is that both of these interventions are viewed as successful and regularly used, and they typically occur in these spontaneous and creative ways to help respond to older clients' needs. The end. Thanks for listening.
And I'd like to introduce Philip from the University of Sydney, and he's going to give us his review of music interventions aimed at musically naive older adults. So over to you, Philip. Thank you very much.
Thank you. Looking forward to, again, cramming a lot of information in a very short time. Hopefully you can see all of that. Let me know if there's any issues. I think it seems to be on my screen okay. So, yes, this intervention is formed as part of the Spencer Bennett Neuromusic Collaborative Project, which is a very exciting collaboration between the Brain and Mind Centre at the University of Sydney and the Sydney Conservatorium. And drawing the strength of both kind of halves of that together. And it's a fairly big team, but one of the early challenges is just to survey, a lot of the literature that's around the idea of structuring musical interventions. Basically, this was something that was tasked for the earlier part of this year. We moved on since then, but a lot of this has formed the foundation of it. And there are still some elements up in the air. So what the task of this review was to look for music training interventions involving healthy or mildly cognitively impaired older adults who were musically naive. So basically anything that involves some kind of musical training activity. As it turns out, there are quite a number of these. There were, I found in the end, 24 distinct intervention models, as you can kind of see there. And alarmingly, 31 of these published studies and protocols. So this is a number of papers that were follow-ups on that as well, and quite some major interventions in the keyboard interventions with Jennifer Bugos in 2018 and 2022, and also some major ones in Europe, the James onwards, and also a major singing intervention in the Johnson series. It's quite remarkable that 16 of these were published within the last 3 years, and I already know of a couple more that are coming out and underway very shortly. So this is a very rapidly evolving field. I'm sure since I've put this together, there's probably been some more since then. In terms of the intervention medium, so what were people being asked to do in terms of the musical training? There was a very strong number of interventions that focused on the keyboard. As you can see, some of those numbers were kind of inflated by the fact that Jennifer Bugos uses that as her model quite over a long period of time. Coming up second in that, there's also been a very strong trend in the last few years for choral or singing interventions to form part of that as well. And then the rest, there's been a smattering of those that kind of fit in with what I was looking for parameter-wise. The xylophone and keyboard harmonica are quite closely related to the keyboard in a number of ways. And then the kind of leaves just rhythmic percussion and also the humble recorder. So generally there was very strong keyboard singing divide. In terms of what they were kind of, how the parameters around these study, prior training was the big one that I'm interested in, still very interested in as an exclusion criteria. Overall, as you can see, highlighted in blue is just the singing interventions, just for reference. The level of required musical naivety was surprisingly inconsistent across all these interventions and often was apparently quite unregulated as an exclusion criteria. Furthermore, what exactly was defined as music training was often left to interpretation, whether sometimes it was specified formal music training, which assumes it's kind of, voice or instrument lessons from a teacher. However, it wasn't clear whether that included, time spent learning an instrument by yourself for leisure or informal choir participation and just, day-to-day music experiences, including formative childhood experiences. 65% of instrumental interventions did define a limit for musical naivety. And interestingly, only 29% of singing interventions did define a limit. Others were quite open-ended. 2 studies didn't actually gather information on participant musical experience. Going on. 5 studies assessed participant experience, but it didn't function as an exclusion criteria. 4 studies required participants to be musically naive, but didn't specify the limits of those. And finally, of the remainder, they ranged quite significantly from 6 months musical training all the way up to 5 years of musical training. So basically just, starting and stopping lessons quite soon versus making a lot of progress on an instrument over a long period of time. And interestingly, the 5 years was, as you can guess, for a singing intervention. What these interventions were aiming to do was quite significant as well. As you can see from that second column, cognitive improvements and measuring those sorts of things was a major aim in most interventions, 71%, as you can see there. Instrumental interventions were strongly focused on that, with 82% of those studies requiring some kind of cognitive benefit being measured. Singing interventions, interestingly, were a little more diverse in their aims, ranging from the auditory, the cognitive, the physical, and also the psychosocial as well. Okay. Now, putting all the parameters of the interventions to kind of work out what the overall intensity of these interventions was an interesting task. So how long do these programs run for was the thing I had to kind of question. Generally, there was a little bit of consensus that over 70% of the intervention models ran roughly between 8 weeks and 16 weeks, or 2 to 4 months roughly. 4 interventions, and I know a couple of others since then, are long-term interventions running up to a year. And 2 interventions were outliers that were very, very intensive ones run and completed within a fortnight, both for keyboard. Okay, how often were sessions held, training sessions? As you can see there, it's quite consistent that one session a week was generally the consensus in this instance. 2 interventions, those 2 that were intensive, completed over 2 weeks, were incredibly intense, ranging from 5 to 7 sessions, so basically every day. And 4 interventions were moderately intensive. So, and these were, again, for instrumental interventions that they were run with multiple sessions a week. Okay, how long did each session run for in terms of minutes? Again, this was an interesting divide. There was a 3-hour intensive intervention, which ran for 3 hours, which was quite demanding, and again, something of an outlier every day. Excluding those outlying interventions, instrumental interventions were generally running around an hour in duration, whereas singing interventions were more close to 100 minutes, possibly with a break in there as well, ranging for a typical sort of choral rehearsal format of 2 hours. Okay, with that, all that data kind of put together, we could kind of work out what the intervention intensity was. So how many minutes per week over how many times per week, and also for how long. So the short intensive interventions obviously were these extreme outliers here, ranging from 900 to 1260 minutes a week. The remainder averaged quite neatly around the 100-minute mark, excluding practice requirements. And while instrumental interventions did vary quite significantly around there, the choral interventions were fairly consistent at around 100 minutes, give or take. So there were some clear divides between this instrumental and singing branch, and as luck would have it, our model is likely going to branch off and do both of these arms in the process. But basically, we could see that there's a roughly equivalent intervention intensity across singing and instrumental divides, and also they fit within the same overall 8 to 16 week duration over the time, which is supported by a lot of the science in terms of the developments that they were after. Singing interventions, generally though, were longer with less frequent sessions. They were less regulated in terms of their music experiencing exclusions. They had a much broader clinical focus, and I didn't cover it here today, but they had much fewer or none or no practice requirements. Key instrumental interventions were much shorter with more frequent sessions, had a stronger cognitive focus, and were also more likely to have to have greater practice requirements than the singing interventions. Thank you very much.